Hi, thank you. Thank you, Susan, and welcome everybody. So today we're going to talk about bleeding a little bit. So just as a brief outline, we're going to go over the physiology of hemostasis, um, diseases that affect hemostasis, because a lot of the times we take these patients to surgery and some of these diseases do affect whether these patients are able to coagulate appropriately or not. And then which drugs can also affect hemostasis. And then we're going to go and delve a little bit into acute blood loss, how to assess it, how much blood can our patients lose, and how much do we need to transfuse once they lose that. And then we're going to talk about a few techniques that we can use to enhance hemostasis, and some of the new stuff that's on the market for this, which is, I think it's really, really exciting. So let's start with the physiology of hemostasis. So hemostasis is a balance, right? It's a balance, and the body is in trying to maintain this balance all the time between an anti-thrombotic tendency, so the tendency of the body to prevent clotting, and then a prothrombotic tendency, which is again a tendency of the body to form a clot. And so like the first one is due to the fact that the body needs to try to maintain the blood in a fluid phase within the circulatory system. So the body is trying to maintain blood liquid so that it can circulate. And the other one is what happens usually when there is a clot formation and a vessel injury. And it's usually temporary, and it's a reversible solution that the body uses to prevent excessive blood loss. Now, after a vessel injury, you have an initial vasoconstriction, and that is to help bring platelets and clotting factors close to the site of injury. And then you have primary hemostasis. So basically that happens when the vessel injury exposes the subendothelium. So that's the layer that's below the endothelium in your vessels. And so that exposes a bunch of like receptors that help with platelet adhesion, activation, and aggregation. And so that forms this temporary and unstable, quote unquote, platelet plug. Platelets are small enucleate discs, so it means that those are cells without a nucleus. The megakaryocytes in the bone marrow divide into many little tiny platelets. And so this is important because we have some drugs that do permanently mess with platelets, right? So like aspirin and clopidogrel, we're going to talk about those in a few slides. But it's really important that we know how long does it take to replace those platelets to the body, right? So if you give a drug like aspirin or clopidogrel that permanently bond to those platelets and make them, quote unquote, useless, you do need to wait for those platelets to be replaced before you probably take that patient to surgery. And so that in dogs is about 6 days, in cats is about 5 to 6, depends on where you read. But in most of our pets is about 6 days. So that's how long it takes for the body to replace those platelets. And then you have, after primary hemostasis occur, you have secondary hemostasis. And that's where you have a little bit of a shape change of the clot, the platelets get activated, the surface of those platelets gets filled with these procoagulant receptors. You have platelets degranulation, and then basically you have the cementing of the temporary platelet plug with fibrin, okay? This is a little bit where the coagulation, the dreaded coagulation cascade comes into place. So I think everybody in vet school hated remembering this, and you'd be excited to know that in reality, the coagulation cascade that we knew from vet school has been, that theory has been dismantled a little bit. Now there is the new cell-based model that kind of replaced what we taught in the past about platelets and coagulation cascade interaction. So, but just to make sure that everybody's on the same page, normally what happens is this cascade has two pathways. You have an intrinsic pathways with the 10-ACE complex, the hands with the 10-ACE complex. So this, combination of factor 9 and factor 8. And then you have the extrinsic pathway where it's due to a combination of tissue factor and factor 7. And that triggers, the common pathway where you have the prothrombinase complex that in the hand bring to the formation of the stable clot with fibrin. So long story short, the coagulation cascade is a series of enzymes, and they're called, in their inactivated form, they're called zymogens, and they become activated to generate this biological effect. What's important to know for us practically is that they require very specific condition to work. So you need to have receptors on the first surface of the platelets. You need to have cofactors, so calcium. Calcium is really, really important for coagulation. So if your patient is hypocalcemic, his ability to form an appropriate clot is limited. You need optimal temperature. This is especially true under anesthesia when we unfortunately make those patients a lot of the times hypothermic, and that will definitely affect coagulation. Usually below 95 degrees Fahrenheit or 94, depends where you read, you're going to have a really, really hard time actually having your patient coagulate. So it's really, really important that we keep these patients warm under anesthesia and for surgery. Like it can definitely complicate your life a little bit if that patient is cold. And then optimal pH. This is, again, another thing that we need to keep an eye on under anesthesia. And there are several factors that do affect pH. So the disease processes, if whether your patient is septic or not. But also, it's as easy as having a patient hypoventilating. So if your patient is not taking good enough breaths, quote unquote, that will make your patient acidotic, and that will hinder its ability to coagulate. A lot of people forget about that, but that's really, really important. In the hand, as we were saying before, fibrin is the end point of the coagulation cascade. It cements the clot. The other thing is that, on the other hand, inflammation crosstalk with this kinase complex that we were talking about. So if you have a patient that's actually septic, it may become procoagulable. So it may actually tend to coagulate more than normal because of the activation of that kinase complex. So again, there is a balance always between the prothrombotic and the antithrombotic tendency. And so those patients, especially with that degree of systemic inflammation, can affect coagulation and in either direction, really. So those patients are a little bit of a coin toss on whether they're more coagulable or less coagulable. The other thing that's really important, and again, people forget about this a lot, is that a lot of our patient population, sometimes especially brachycephalics and whatnot, they tend to be overweight, right? And patients that are overweight, all those adipocytes make you live in a state of constant inflammation. So it's a constant low degree of inflammation. And so it's actually been well researched and proven in humans that if you are overweight or obese, you actually have a higher risk of being prothrombotic. So the chance of deep vein thrombosis, for example, in humans skyrockets if you're overweight. So that's something that unfortunately we need to think about a little bit. And then after the clot is done and the vessel is repaired, there is fibrinolysis. So that's the destruction of the fibrin. They break it down. The vessel goes back to normal patency. And then this breakdown of fibrin is catalyzed by plasmin. And then there is the production of the dimers, right? So the fibrin that gets destroyed releases into the bloodstream the dimers. And so those could be used. It could be measured. So there are some companies like, that would measure the dimer. So that's an offering on their blood work that you can send out. And that can be used to assess pulmonary embolism, for example, deep vein thrombosis and that stuff. So that's something that, it could be a useful tool to gather that kind of information. So the body, again, has some endogenous anticoagulants. So some of them are platelet inhibitors like nitric oxide, prostacyclin, ADPase. Some of them are anticoagulants like antithrombin, thrombomodulin, tissue factor inhibitors. And then you have some others that actually the tissue plasminogen activator, the TPA, that actually activates fibrinolysis. So this is something that's being researched more in humans, and it's coming way more in med too. Like a lot of people, well, some internists are using it in horses, for example. It's an interesting thing that can be used to like get rid of some clots. So this is what they will give you if you get a stroke or whatnot. So, or if you have like coronary disease and you get a heart attack, they will give you tissue plasminogen activators to break down clots in your vessels. So again, our patients can live endogenous, like they have endogenous things that keep them, that prevent them from clotting. But also there is a lot of other things that can affect their ability to clot as well, that they're not, that they're abnormal, right? So if you don't have enough platelets, if you have dysfunctional platelets, if you have von Willebrand disease, and we're going to talk about this in a couple of slides as well, those will affect your primary hemostasis. So those patients will tend to bleed more. And then there are things that affect towards your secondary hemostasis. So like if your clotting factors are affected, if you have hemophilia, if you have patients that have been exposed to rodenticides, or patients that are in DIC, that's something that will affect your secondary hemostasis. And then if you have an hyperfibrinolytic state, so if you have an excessive clot breakdown, of course, that's something that will put your patient at a higher risk of bleeding. So any patients with those, you definitely need to keep an eye on before you bring it to surgery and try to figure out, okay, we need to fix this before it gets too risky for us to go forward. So let's talk for a second about von Willebrand disease. There's a bunch of patients that we see that have some degree of von Willebrand disease. The most common in Doberman, Sheltie, Standard Poodle, and German Shepherds is the type 1. Type 2, it's more common in German short-haired pointers or wild-haired pointers. Type 1 is not usually, there is an increased bleeding risk, but it's a moderate bleeding risk versus like these German short-haired pointers or the wire-haired pointers. They actually, with type 2 von Willebrand disease, they bleed like hell. So that's a very severe bleeding risk, and you should be really careful with those patients. Another thing that people don't realize that there is described a type 3 von Willebrand disease, and that's the acquired von Willebrand disease. There is a lot of things that can affect us, and there is a huge list here. It's pretty long. It took 3 slides really. But one of the things that you definitely want to focus, and it's really important, is, in the past, people will use, when you had a patient that was bleeding, to improve their volume status, they would tend to give starches. So hydroxyethyl starch or head starch, vet starch, all of that. Those do actually make your patient clot less. So actually, they're working against you. Yes, it fixes your volume status, but then they're not going to be able to coagulate appropriately. So you can't use that, or you shouldn't be using that as a way to assess to improve the volume status in a bleeding patient. And then, the list goes on what actually does affect the von Willebrand factor. Okay. There is also inherited factor deficiency. So every patient that has, one of these, you need to be really careful again with them bleeding, and you need to have a plan B in if they need surgery, in what to do if they start bleeding. And so there is, on this table you have on the right-hand side, you have the most common breeds or species affected. And so as you can see, there is a huge list of potential breeds that we need to be careful with this specific potential clotting factor deficiency. The other thing that's going to potentially make your patient bleed more is patients that have vitamin K deficiency. Okay, vitamin K, it's required for clotting factors 2, 7, 9, and 10 to actually work. And so that's really, really important. You can have an absolute deficiency in neonates. So if you have a patient that's really, really young, potentially is going to have some deficiency of vitamin K. Patients that are in total parenteral nutrition, this is something more common into internal medicine or ER settings. Patients that have been exposed to antagonists, vitamin K antagonists like warfarin or rodenticides. And then patients that do have an absorption issue of vitamin K. So patients with severe GI disease, hepatobiliary disease, biliary obstruction, all of that. Now, the other thing that, people don't realize is that when you have a patient that bleeds a lot and has acute hemorrhage, and you replace that with a bunch of fluids, you're actually diluting out those platelets. And so it's going to be harder for the patient to coagulate. Now, we do need to fix the volume in these patients, right? But by giving fluids is a temporary patch, we need to give something to help those patients coagulate as well, or use some external things that can help those patients coagulate and form a clot. So this is called dilutional coagulopathy, and it's a real thing. It's something that we do see, unfortunately. Hypothermia, as we were saying before, usually depending on the degree. So if you're between even like 98, I usually start seeing it around 95. This is a huge, very wide range that you will find published, but in reality, again, I usually below 95 or 96, that's when I start seeing this issue. You will have altered von Willebrand factor platelet adhesion. And then if you go below 91.4, then you have a massive decrease of the tissue factor and factor 7 complex. So it affects that part of the coagulation cascade as well. And then acidosis, of course, if your pH is 7.2, the activity of factor 5, factor 10 complex is reduced by 50%. If you go at 7, that's decreased by 70%, and then factor 7 is actually decreased by 90% effect. So those patients, you can't rely on the physiologic coagulation cascade too much for these guys because of those deficiencies. There is other diseases that, again, we were talking about in the slide, but these are the ones that probably it's worth talking about because we see it all the time. Acute and chronic liver injury, those do affect your coagulation for sure. Your congenital portosystemic shunts, they also do affect them as well. So anything that affects the liver can massively affect your coagulation as well. So all of those patients, you need to have a plan B in place. This is a little bit, a diagnostic tree of like an algorithm that you can go and, and try to like figure out what the actual issue is. But in reality, all of those diseases will make your patient hypocoagulable. Okay, so they will tend to bleed more. How can we assess it? Again, BMBT, it's something that's used to assess your primary hemostasis. Usually you need to use a gauze to tie up the lip of the buccal mucosa. So usually, roll gauze and you hold it up. You can use a lancet, and you need to try and avoid visible vessels that will hinder your test. If you do hit one of those, you need to start a timer when the bleeding is visible, and then you should not apply pressure to the bleeding site. And so if the bleeding stops in 1.5 to 4 minutes, that's normal in dogs, and between 1 to 2.5 minutes, that's normal in cats. Of course, this test has a lot of issues. Like probably every one of you tried to perform one of these at some point in their career. Patients hate it, of course. And so if they're not compliant, that's kind of a problem. The skin thickness sometimes is an issue as well. The hematocrit, if it's too low, you don't want to be having that patient bleed too much. The vessel pattern can mess it up, and then each person can do it slightly differently, and so that there is that variability between different operators, right? So that's something that it's really hard sometimes to gather a good results from this, right? Another thing you can use, and this is a little bit more fancy, it's a PFA 100. It's a machine that basically assess clotting, platelet function. It can't assess hyperactivity, so it only tells you whether your patient is hypocoagulable, but not if it's hypercoagulable. The normal values for this is 60 to 120 seconds in dog and 60 to 180 in cats. Of course, like prolongations of this, it could be due to von Willebrand disease, acquired von Willebrand disease, right? So all of those things that do affect the von Willebrand factors. And then you can have also intrinsic platelets disorders like Glanzmann disease, for example. There are some other diagnostics that assess secondary hemostasis, like prothrombin time, so PT, APTT, all of that. In reality, nowadays, most people will try to assess with a viscoelastic monitoring. That's the best way to do this. It gives you a full picture of what's happening with coagulation. So TEG, it's been the gold standard for a while. VDM, it's coming in as well. VDM, it's actually probably the cheapest and most affordable option of these. They're actually really tiny machines, and they work with cartridges, and I think they're actually extremely affordable, and so it's something that probably it's worth having around if you do some of these more complex cases. And basically, they give you a graph like this, okay? And so the first bit, the R time, is the time that it takes to start forming the clot. And then you have this blue area here, the K time, which is the time till the clot actually reaches a fixed strength. And then you have the alpha angle, which is the speed of fibrin accumulation. And then you have the maximum amplitude here, which is the highest vertical amplitude of the tag. And then you have the lysis at 30 minutes. So that's the percentage of amplitude reduction 30 minutes after the maximum amplitude. So, you have some you can use that, and it's coming back a little bit. It's coming more and more into clinics. So that's something that you guys could use. Now, it's also important to talk about the most common drugs out there that affects your coagulation. So antiplatelets drugs like clopidogrel and aspirin, for example, those can be best for arterial clots. Patients that have a prothrombotic tendency may benefit from these drugs. Some of this, it's not fully researched in our patients, and so there isn't a lot of in-depth research with this. We're working on it, but it's not something that it's as well researched as it is in humans. Other drugs that are used are like vitamin K antagonists, heparin, direct oral anticoagulants. Again, this is controversial as well, but you may have some of those patients coming into your clinic that are on some of these drugs, and so you need to be aware of the fact that there is an increased risk for those. And then on the other side, when you have patients that we want to make them coagulate more, you can give drugs that also improve coagulation, right? And so like tranexamic acids, for example, epsilon aminocropic acid, those are drugs that are antifibrinolytics, so they will help your patients coagulate a little bit better. Usually those are used for like severe trauma, surgical bleeding. Gray hounds are one of the breeds that are very commonly at risk of bleeding after surgery. And then you can use like desmopressin. This is used relatively infrequently, but it does increase von Willebrand factor release from the endothelium. A lot of people use this for patients with von Willebrand disease, but it can be used to increase coagulation in normal patients as well. Prodamine, it's something that probably is not used that common either. This is something that's normally used to reverse the effect of heparin. So if you have a patient that received heparin, prodamine can be used to reverse it. And then Yunnan Bio, that's probably the most common drug out there that people use to improve coagulation a little bit. And so it's a Chinese herbal drug, and the mechanism of action is not fully understood at the moment. So but people do use it, and it seems to work. It's just we don't know how, really. Other things we need to be worried about is patients that are anemic, right? So now we went into, okay, what drugs or what things make your patient bleed more? We looked at a couple of things that makes our patient coagulate a little bit more, depending on, the first are probably more useful to understand when, a patient comes in with those, and, we need to be more worried and have a plan B when we see some of those on their charts. And then the other ones are, stuff that we can do to kind of improve coagulation in these patients. But one of the other things that we need to keep in mind is, why do we care about blood loss, right? We do care about blood loss because our patients need enough red blood cells to carry oxygen around, and they need to have enough volume to have a normal hemodynamics. And so if your patient is anemic to begin with, it's a much bigger issue. But also you don't want to get your patient to become anemic. So you need to limit blood loss as much as possible. You do need those red blood cells in the body. And so anemia is defined as a reduced number of erythrocytes, and usually in dogs that's below 38%, and in cats is below 24%. So that's our definition of anemia. How do we test for it? You could run PCVs, TPs. The problem is that if your patient has an acute blood loss, then the total protein takes 1 to 4 hours to actually decrease, and PCV decreases after 12 to 24 hours. So taking a PCV TP right after the acute blood loss event is not going to tell you anything, right? So the key to acute blood loss is try to fix it as quick as possible. You need to have a plan B in place, okay? Post-op, you can do ultrasounds to recheck for hemorrhage in some situation, like, if you had an internal abdominal bleeding, if you have a limb-associated bleeding, and I've seen this for TPLOs where they unfortunately hit the popliteal artery, and so that you can use soft tape to keep track of the circumference of the leg. So those are things that you can totally do to keep an eye on that bleeding. But again, you can't rely on PCV that much. TP gives you an earlier idea, but again, with our ability to assess it is kind of limited. So how much can our patients lose, right? So the blood volume in cats is 60 ml per kg, dogs is 80 ml per kg. Normally, most people, if you ask, they'll tell you, you don't want them to lose more than 20% of the blood volume. Now, that's it's a conservative measure. It's not wrong. And that's when you will start seeing the hemodynamic effect of the blood loss. So that's when you start seeing the heart rate skyrocketing, blood pressure dropping, that's when you start seeing that. But in reality, you can calculate how much blood loss the patient can afford, how much blood you can afford to lose based on the starting PCV of that patient or starting hematocrit, and what's your target for that hematocrit. And so by using this formula, right, where you multiply the blood volume by the difference between the starting PCV and the PCV that you want to hit, so like the 20%, which is our the lowest PCV that we would like to tolerate in our patients, and you divide that by the starting PCV, that will give you a number of like how much blood that patient can lose before it hits that 20% of PCV. And so if you have a 20 kg dog and the starting PCV is 45 and our cutoff is 20, then the allowable blood loss formula will give you a blood loss of 880 mLs versus using the 20% of blood volume formula that gives you 320 mLs. So that's way more conservative. Now, it isn't wrong to be more conservative when we're talking about blood loss, right? When you start hitting this 20% loss, that's when you start seeing the hemodynamic changes. So that's something that it's really, really important to keep in mind. how do you assess it? Well, you need to figure out how much blood the patient lost, so how much is in the suction canister. But also you need to look at like your sponges, right? The sponges, unfortunately, they do take a lot of volume. So a 4x4 sponge, if it's soaked, depending on the material, it can absorb a lot of blood. So like a non-woven, for example, 4x4 can hold up to 18.3 ml each. A woven one holds a little bit less, between 5 and 12.5. And then woven laparotomy sponges can hold between 50 and 100 ml. So that's kind of a lot, right? Like, so, we need to make sure that, we keep track of those and like we add it up. And you also want to keep track of how much saline is in your suction canister, of course, because the more saline you put, of course, the more diluted it is. So, the volume that you're seeing in your suction canister is not always real, right? It depends on like how much flush you used. So it's good practice to keep track of how much flush we're using and whatnot. So you can also measure the PCV in the suction canister. That's another way of doing it. That gives you an idea of what, how much of it was actual blood and how much of it was flush. So that's a good way to do it. It's just sometimes it's when you're in a rush and you're trying to assess the situation, it's not something that you really have time to do, So how much shall I transfuse? Well, again, we go back to the blood volume of the either dog or cat, and then you multiply by the difference between the desired hematocrit and the starting hematocrit. And then you want to divide it by the PCV or the hematocrit that's in the bag. And so that gives you an idea of how much volume do we need to transfuse. So going back a little bit as a summary of our normal hemostatic response when there is an injury, again, we said you have vasoconstriction, primary hemostasis, secondary, and then the stabilization of the clot. Now, this should happen if everything is fine with the patient and everything is normal. But again, we saw it in previous slides that this isn't the case a lot of the times. And so that's something that we need to have a plan B. And so we do use several different hemostatic technologies or things that we can use to make our patient clot, quote unquote, at will. Okay. You can use tourniquets and compression. So that works by putting pressure on the vessel and reducing the blood flow. You can use absorbent materials. And so like dressings and those absorb the blood and protect the wounds. Those are used to like usually underneath vet wrap and whatnot to like to try and stop the bleeding. You have some bioactive material like collagen, gelatin, or chitosan that promote platelet activation. Fibrin sealant, a lot of these are fibrinogen and thrombin mixtures that help to form clots. Again, these are all external, so like you cannot use this inside the cavity. Okay. Some hemostatic biomaterials are natural, so they're either collagen based, so either derived from bovine or some of them are chitosan based, some of them are fibrin based. So there is several different materials that can be used as like natural hemostatic biomaterials. And so those are they're acquired from, crustacean shells or like final step of coagulation cascade. So like, those are often very, very expensive to acquire because you need to harvest them from something alive. Okay. And then you have synthetic hemostatic biomaterials, so like polyurethane films or foams that create moist wound environments, and they still allow some sort of gas exchange. You have cyanoacrylate adhesives, so like liquid glues that polymerize upon contact. And then you have self-assembling peptides, and they form these like nanofiber scaffolds and in presence of blood, and they hold those cells in there. So there's several materials, there's several options out there around. Now, what are the pros and cons of those? And those are all usually external, so you cannot use those inside the cavity, okay? So the natural ones are really expensive. So you need the donor, you need screening, it's a mess. Natural have variable duration, so they may degrade more quickly or slowly depending on the source. Some of them may cause allergic reactions. Okay, so fish or shellfish, bovine, they can cause allergic reactions. And then natural may require holds of refrigeration and can be sticky and variable in texture or behavior. So those are usually a kind of a pain to deal with, and they're usually not really, if I had to pick one, probably I wouldn't use one of those. Synthetics, of course, they are not effective in anything that's deep or non-visible. So it requires access. You need to apply it there. They have a lot of limitations. This stuff there's a lot of options, but the ones that are actually useful are very few. And then the other options you have are intracavitary hemostatic technologies, and those are either self-expanding foams like polyurethane-based materials that expand and fill cavities. They do applied pressure, and the drawback of this have been going around for a while, but the huge drawback of these guys is that people don't realize, but the material is biocompatible, right? But the chemicals that are used in their production, like isocyanates, and usually about probably, most of them do have isocyanates in them. Those can be irritants and can cause allergic reactions. So those are not really ideal either. And then you have expandable sponges, right? So those are using cellulose. And so when it conducts blood, it expands, but the problem with this is that 16 to 24% of the content of these guys are oxidized cellulose, and that has a pH of 3.1. It's not ideal for wound healing or for healing of that bleeding site. So these have been going around for a while, but in reality, if you look at it, it's not something that if you ask me, it's less than ideal. Okay. And then the other options you have are injectable gels, and those are usually alginate based. There is in the human market, they were used a lot in the military. Those were developed initially by the military because they needed a way to stop that bleeding in battlefield situations. And then they licensed it, as a product that's commercially available to all doctors. And I think recently this has been introduced in the veterinary world as well with Vetigel, I think. So they provide this hemostatic barrier in deep wounds. They're made by, with alginate, which is, a very safe material. And so basically the way it works is that basically it's a gel, you just inject it into the area that this is a liver biopsy, for example. You inject it into the area, it creates a blob like this, and it stops your bleeding. And there is some research that actually showed that how, and a lot of the research, unfortunately, again, it comes from the human side, but the gel is exactly the same. So, and there's compared intracavitary um, technologies again versus like cautery compression or ligation. And so, when applied to internal deep bleeds, these intracavitary hemostatics are way more effective than normal compression or cautery. They're superior to cautery compression or ligation for non-compressible hemorrhage, so liver lacerations, pelvic trauma, retroperitoneal bleeds. Those are way superior than our common techniques. You don't need a huge access requirement, so you can use it blindly or laparoscopically. That makes it very easy. You need less training, of course, right? Like, so if you if you have a lot of experience, of course, like cautery compression ligations, they may work really well for you, but in reality, we all had these difficult cases where you're like, hey, um, I'm kind of in a bad situation here, and you always wish that you had the plan B situation here, right? And so it's consistent, right? So the other techniques like cautery, for example, or ligation, they really heavily depends on skill. They're way faster than compression, and it can be also faster than cautery and ligation, again, depending on skill. So I think it's a really good plan B option, right? Where, when other techniques fail, or, if you don't have a really good access, this is a really good option to stop that bleeding before we get to a really bad situation. So I think that's about it for today, and I'll take all of your questions, guys. So, okay, so there is a couple of them in the
Yeah.
Q&A section.
Yep, I can see them. And looks like we've got a few that come through. Before we get into those, I just want to remind everybody that your CE certificate will be sent to you within the next few days. So keep a lookout for that. If you don't see it, check your spam or your junk folder. Sometimes they tend to end up there, but it should be coming, like I said, pretty quickly within the next few days. So Dr. Bini, let's jump right in. Let's see. First question I can see. Any experience with, oh, help me with this word.
Aminocaproic acid,
Thank
yes.
you.
So those are, those are used, and I'm going back to that slide. So those are antifibrinolytic agents. Yes, they do work. Okay. Now, how well they do work, it's really dependent on the patient, unfortunately. So the reliability of it, I'm not saying you shouldn't use it, but whether you need to 100% rely on it or not is probably not. It's probably no. The Funny enough, when I had my tonsils removed, like probably like what, 10 or 15 years ago, I was an adult, and they sent me home with 2 bottles of um, tranexamic acid, and they're like, if the stitches come out and you start bleeding, drink those and then run to the hospital. But they're not. You can't rely on them, right? Like they work really well in some patients, they don't work as well in others. It is something that you can do to help, but again, I wouldn't put all my money in it.
Okay. I do have a request. Someone is asking, can you please show your reference list slide again?
Yes, and that it's not super updated because I was putting some other stuff in it. This is one of them, but I have some others throughout the slides, so that's my fault. Do you normally share handout with them, or
We do
is it?
not. So
Okay,
what we do is actually today's webinar is being recorded and it will be posted on our Zomedica website probably within the next day or so. So if anybody wants to go back and rewatch today's recording and pick up any of these references, you can certainly do so. It will be at zomedica.com under the learning tab, I believe. Let's
perfect.
see. Let me see what the next question is here. Any risk or concern, for example, regarding Vetagel with it entering the bloodstream or circulation and causing an embolism elsewhere?
So I never seen that happen before, and I don't think there is enough literature behind this in veterinary medicine. In humans, they've been using this gel for ages.
Okay.
It's made of like sodium alginate, basically. Um, I can't give you a straight answer on this, but for now, in our patient has never been described. Um, in humans, I never read of it either. Um, will it happen tomorrow? Maybe, I don't know. But I don't think we have a lot of data on this happening. I couldn't find anything about it. But again, it's non-homogeneous. It's really highly biocompatible, has a very stable pH. Usually what it does, it creates this like kind of mesh in there, and it helps, the cells to grow around it. So it's not liquid, like it's liquid, but it's a gel. So it doesn't really hinder circulation very easily. Also, the pressure from the vessel pushes it against it. So it's really, really hard for it to hinder circulation. Now, if you go and inject a straight IV, that's maybe a different story, but in a normal situation where you have bleeding, um, the blood keeps it, it pushes against it, and it is such a like gel form that it's not liquid enough to enter the bloodstream. I think that's why we don't see any of those reports out there. But
Okay.
in the military, they've been using it for decades. So it just made it to our market very, very late. We're always kind of behind in vet med, unfortunately. But thankfully, somebody picked up on this, and we now have it available.